going to put you on record. So welcome to Pediatrics. You all should be very proud of yourself. You are now one semester, most of you, away from graduating. So this semester is going to get hard. And I just want you to know that I do some things to try to help you, because by week 8, you're going to be pulling your hair out. And especially those who work and work full time, listen to what I have to say. Now, case studies, I do not open early because I want you to study them on the areas where we're going to be studying those diagnoses and those conditions, okay? But your NCLEX questions are open, and your case studies, your next gen case studies are open that you can go ahead. So NCLEX you can do, and I also leave discussion questions open a little early. But if you take and save them and post them on the week that they're due, make sure you do that, because remember, you have to post something in Canvas to get your attendance in Canvas. Very, very important. If we see that you have posted early and there's nothing for that week, it could be a week of non-attendance, even though you came to class. Okay, so it's a twofold thing: attendance on Zoom, which is mandatory, and then attendance in Canvas by posting. But I do leave those open. And as we get through going through the other assignments, I'm going to tell you what you can start on now, which is a big project. It's the Pediatric Assessment Project. And you can start figuring out a diagnosis now. You might know somebody with something, or you have, or your child has, or your friend has, or your sister, brother, aunt, uncle, and you want to know something more about it. And it could be related to a pediatric diagnosis. You can do your pediatric assessment project on that, because it is 6% of your subjective grade. It's due week 8. But week 8, you can have a community project due too. So it's going to be pretty crazy by then. And then, of course, you have the exam the week before or exam the week after. And I don't want you all to get to the point of, what do I do now? So I tell you, try to get it in earlier. And if you send it to me, I can tell you where you can correct it so you can get a better grade on it, okay? So today, what are we going to do? Well, number one, let me just introduce me, and so you know who I am. I know a lot of you have heard about Professor Bogart. Yes, I've been at Fortis for quite a while. I joined Fortis in 2017, and I taught pharmacology and pediatrics. Now, pediatrics is my love. I've been at a area pediatric center that is international, world-renowned. The old Miami Children's Hospital, which is now Nicholas Children's Hospital. The golfer gave millions of dollars to the hospital, so we changed the name. You give us 60 or 80 million, whatever it was. Yeah, we're going to change our name. So we did. But it is really a progressive hospital. Now, I have worked in the newborn ICU, pediatric ICU. I've worked in the cardiac intensive care unit, which is my absolute favorite of all nursing I've ever done. In fact, I opened the unit when Dr. Burke came, so I really love that. I can actually see blood pumping in my head the way hearts work. So I'm going to try to describe that to you by using the reference of a garden hose. If you kink a hose, what happens? Where does the blood flow? And if you think of that backwards flow, then you can figure out what's going on with the heart. But we'll get there. That's week 5, just to let you know. Now, the last 10 years, I was a primary trauma nurse in the emergency room. And I have seen almost every diagnosis that we're going to see. There's some syndromes you never see, they're so rare, but I've seen quite a bit of what we are going to talk about in class. So I've got stories about everything for you. So actually getting this extra half hour that we've done for pediatrics this semester will avail me to giving you more of those stories. And I think those stories will help you remember what those things are all about, what to look for, what to see, how to treat. And I think it will help you remember, because up to this point, most of you are memorizing information. From now on, I want you to start applying it. Like, okay, I see this. What does it mean? What do I do? What do I do first? And what do I want to see happen? Did it work? And we're going to be talking about that. So how am I going to get that done for you? Well, I'm going to be giving you a PowerPoint every week. And I want you to know I review and update these PowerPoints every semester. And I update them according to the results of the HESI that comes out. The HESI gives me topics that those were not done well. Students struggled on them. So those concepts, I'm going to focus in my PowerPoint to make sure you understand. So you can hear, I'm not only teaching you for exams, I'm teaching you for HESI, and I'm teaching you for your NCLEX. So you're going to get a lot of information. Also, after a PowerPoint, I'm going to do a Kahoots. These Kahoots are an instant testing of the knowledge I just gave you and the concepts, so that, okay, you now have seen them twice. Now, if you come to class and at least reviewed the PowerPoint, try to figure out what stuff is or review the chapter quickly, that's one time over. Then I teach you that second time, and Kahoots is 3 times. And we know with learning, 3 times is that repetition, and you're going to remember these things. So that's the way you learn more. Now you will be getting exam reviews. Every professor does do them. And I also have a YouTube channel. It's Professor Bogart Pediatric Nursing. It's open to the public. It's there all the time. And I've got from last year, January up, and I post every class that I do all the way through. So there's so much information for you to have. So let's go over what your requirements are for this course. It's just that online learning component that you need to know. So the rules, the regulations, what do I need to do? How do I succeed? So we just redid this because we're doing a lot more different things. We're making our program better and better and better for you. So we know that online learning can be really, difficult. But just think of this as a classroom. You're coming to a classroom, I'm teaching you. Then you've got your sim and you've got your clinicals with different professors. You're going to get 3 views of different professors, the way they teach. You're going to like one more than the other. And, you're going to have bosses you like more than each other. It's just try to gain as much knowledge from one that you can. In the class, if I'm teaching and I mention something and you don't understand it, I want you to stop me. I'll just say, Professor Bogart, I don't understand. I am never offended. I never get upset because, again, a question you don't know the answer to is not a silly, stupid, or dumb question, because probably somebody else doesn't understand it too. So you'll be helping out everybody by saying, wait, I don't get that. So please, stop me. Every week, week is due, and we're going to go over into doing that. So problems, who do you contact? Well, I am the lead pediatric professor, so I'm the pediatric person that you will contact first. Now, you can't get a hold of me, which is unusual because I'm usually answering up till like 9 o'clock at night at least, answering questions. I, always have the phone next to me, of course, and then I've got everything programmed there to look. And I will answer you quickly. But let's say I'm not, or I'm not giving you the answers you want. Please contact Dr. Brown. I'll never be offended. I don't get upset because she understands I'm doing the best I can do. And you have an answer. You have a question you don't have an answer to. So she'll be there to help you. Her email, it is not D Brown, it's Darlene.Brown, because there is another D Brown in the Fortis system. So make sure if you're doing an email, send it to Darlene.Brown or call her on a phone. And that's her Google phone. So don't be afraid. Call her, leave a message if she doesn't answer, because she is always on some sort of different meeting call. So again, call me first, message me, email me. Now, what if you're in that moment where you only have a little time to get something done, which could be for some people? Message me on my phone. Now, you have it listed on the welcome sheet in Canvas, but here's my phone number also. It is 305-951-8055. Send me a text and I will get back to you pretty quickly, okay? So if you need me quick, use it. But if it's something that can wait for an hour or two, or maybe till the next morning, please message me in Canvas. And because you're messaging me in Canvas, it also shows that you try to contact me before maybe assignment was due, that you couldn't get it done, because that's what we want you to do. Contact me before things are due if you're having issues, okay? So with being, communicating, just be respectful. You don't have to come to class in your Fortis uniform, but don't come in class, in a bathing suit top, or, in bed in your nightgown. Just please be more respectful in your clothing, okay? I've seen crazy things, so you'd be surprised. I've actually seen husbands behind them walking in the bedroom naked. Yes, we've seen stuff like that. So seeing wives in the background with their bras on. So it does happen. So please remember those things. And if you're emailing me or messaging me, I didn't realize it, but in caps it's saying that you're yelling at me. So just make sure you're not going to put everything in caps. Start times, end times are very important because we do have the opens up on Monday, 12 midnight, or Sunday at 12 o'clock at night. That's when the assignments are due. And it ends on Sunday, 11:59 Pacific time. So whatever that is for you, it could be, 2:59 a.m. or it could be 4:59 p.m., whatever it is for you. Know that there are different times, but it's 11:59 Pacific time. Now, first assignments due is a discussion board. Please, you're going to do it by tonight, 11:59. A lot of you have done it already. I saw that. And I do read these things. I really pay attention to it. Some students tell me so many interesting things about where they've seen, what they've done, maybe their child, maybe themselves. And I really like to see that part. I get to know you quite well, even in an online forum. Make sure when you do these discussion boards that you do it with references when you're talking about a topic. The first discussion question has something about nutrition. Okay, it's not just telling me about you, something about nutrition and cognition and how does that affect it, etc. Make sure that you have a reference there. Remember, you have a book. That's always a reference, okay? But during you're writing this couple paragraphs that you're going to write, make sure you put a citation, those quotations with Perry et al., 2023, put that in there so that it is part of the APA. Always follow the syllabus. The syllabus is your guide for work, okay? Now, if you can't get work in by Sunday, that discussion question, let's say, if you don't get it in by Sunday, you haven't notified me before then that, you had an emergency, you were in the hospital, you had an accident, your kid something, I don't know, then I can accept it up to 1 week later, but it will be a 10% deduction in any sort of the assignments, whether case study, NCLEX, etc. So try to get it in on time. If you notify me, I will not take that 10% off. So it does behoove to you to communicate. So attendance is recorded only through the live sessions. We used to have those attendance attestations. We're not doing them anymore, okay? The attendance will be done with me. So as what I'm having you do now, make sure that your cameras, your Zooms have your full name that is known by Fortis. Sign in the chat box with your campus so I know that who you are. If you have to go off screen or if that's going, cameras sometimes we see up into the ceiling, that is not attendance, okay? So I want to see you. I don't care if you drink. I don't care if you have something to eat. I understand children are around. I know that. But try to keep it as a professional environment as you possibly can. I know that you guys are, running, burning the candles at both ends. So I understand those things. So that's fine with me. Don't worry. Now, from this day on, if you are late, and I'm going to put it as 3:05 p.m. Eastern Standard Time, you will be marked 15 minutes late for every minute over. So if it's 3:06, it's going to be 15 minutes. So be careful. If you sign out early, again, 15 minutes will be taken off. And you're like, what is this all about? Well, we have to show that you have involvement in class. It's all parts of accreditations and all of these accrediting agencies, that there's a certain amount of hours we say that pediatric students get. And if you don't have that much time, they're going to say that, how are you managing this? How are you monitoring this, to make sure that they're getting the hours they're supposed to get. So we will be monitoring it. Now, Zoom has a great thing where I can go and check, when did you sign in? When did you sign out? I can see if the internet cut off, that you had to sign out and had to sign in. I look at all those things, and then I'll put the assignment, your attendance in there. If you are late, they're going to be doing this policy. If you're 5% of your time, 10, 15, and 20% of your time, they will be notifying you. So you're aware that you're getting close to 20%. And 20% is when we will be taking one full grade off of your final grade. So if you had a B+, you're going to be a C+. If you had an A, you'll be a B. And I don't want that to happen to anybody. Now, I know some of you sometimes have to go do something, sign in late. It's better partial credit than no credit, okay? So as I said, full grade deduction for those, and you'll be getting 5%, 10%, 15%. You'll be getting notification. So you know where you are. There'll be no question at all, okay? So how do you be successful? We have a syllabus. It shows you what's due. I also post it every week in the announcements to tell you what is due, so that you go look. This week is, yes, this is the first week, but we do have a discussion question, and that is due, and that's going to be marking your attendance for the week in Canvas, okay? I will tell you every week, and I will be posting it. Now, I know that you get a lot of announcements, and there's some teachers that are announcement happy. I'm not. I'm not going to be sending you 100,000 announcements. The first week you get a few because Dr. Brown wants us to send some, but I'll just put up the introduction, welcome, and I'll put what your assignments are there. Tomorrow, I'll be saying recordings for week 1. So the information will be week 2 information will have what you need, and the PowerPoint will be attached. On week 2 recordings will be just my YouTube recording and the Kahoots. And again, I attach the PowerPoint. So you know that those are where you're going to find your information. If I have a multiple type things that I need to send, it'll be sent through Canvas as a message. I think you noticed that you got a handout on Erickson and Vital Sign sheets. Those came to you through Canvas because they were 2, and I can't attach more than 1 to an assignment. So those 2 were sent out last night. So you need to let me know what's going on. Just keep in contact with me. Let me know what's up with, going on. If you don't understand, please, I can work with you, but I can't work with you if you don't tell me before. I can't just tell you enough about that. Always make sure you're logging in, see what's going on. And of course, try to do those assignments and get them in when they're due. I do send little messages. You didn't do your discussion question. I'll say, and please get it in by Sunday. I know sometimes you forget, or, you're studying for another exam or 2 exams or whatever. I will send you little messages so that you'll know if something's not in there yet. So day 1, make sure you go in, make sure that you put your syllabus where you want. Some people like paper syllabus, some just do a digital one, whatever you like. Have it in a place where you can go up and look and see what is due, okay? Go in and do those quizzes that are there so you can open up your week 1 and make sure that you have your textbook open. It's the same one that was used as maternity, but we start at chapter 26. If you can't find something, let me know. As in coming to class, as I said, if you come into class just looking at the information, you might have some information, okay? And then you want some questions about it. Please come, ask me all those questions, okay? Now, I will be doing review sessions for your exams, and I'll be doing it for the HESI. I've got some really good tools that I use that have been very successful in the past semesters, and they're updated again every semester, like I've told you. If you're not getting it, you're lost, you need help, please do not hesitate. I will work to set up a one-to-one, or maybe it's 3 of you and me, set up something with you to work together, to talk about it, to make you understand whatever concepts you don't understand. And if you're having any problems with your computer, technology, anything, number one, if it's a technical support thing, send in your help tickets, or contact me. Let me know what's happening. This is especially when you're trying to get something in and your internet went out. I've seen ice storms, and I've seen down in Florida hurricanes, right? So anything, let me know. So I don't do formal weekly review sessions, but I am here to before class, after class, to help you. And again, tutoring, whatever you want, I will work it into my schedule that fits yours, because I want everybody here to pass. I do not like when a student is not successful in my class. So how is the grading worked? Well, we have unit exams, quizzes, and your HESI. That is 80% of your grade. The other parts are going to be the homework or subjective grades. And you'll notice that pediatric assessment is 6%. So please don't lose points on not getting these things in, okay? Now, we do something with the homeworks where, weeks 1 to 5, you're just going to see your quizzes and your exam grades, okay? On week 6, we turn on the homework to show you how it affects your grade. And then on week 8, I turn it back off again. It will not be turned back on until everybody's completed the HESI and done the remediation, and then that will be your final grade for the course. Okay, I can't turn just one student's on. I have to turn on the whole class. Okay, so that won't be done until that point. And of course, I'll be telling you if you're missing stuff. If I'm worried about you with your subjective grades, I'll be sending you messages. So we know we need a 78 on the exams, quizzes, and the HESI in order to be able to be considered to pass. That's we add on the subjective grades. And I'll warn you, I've seen students do well, have an 80-something on their KGA, those exams, quizzes, and HESI, and then fail because homeworks weren't in. So don't be one of those that let the homeworks fail you, because it can. Now, we will be doing quizzes in class this semester. Next week, you will have your first quiz. Now, because this is a newer thing for the online learning, I'm going to give 2 quizzes, quiz 1 and 2, at the end of the class. And why am I going to do it like that? I want you to see what we're testing on, so you'll know what to study before you come to class so that you can be successful. And every quiz has been changed this semester. So there are new quizzes at the beginning of the class for quiz 3, 4, and 5. But next week, the first thing we're going to do is the quiz, okay? And it's going to be the same way, 15 minutes, and it's going to be only going forward. You cannot go back, all right? And we're probably going to be giving those about 5 o'clock for the first 2 questions, 5 o'clock Eastern Standard Time. So listen to the lecture, look at the Kahoots, see what the questions are coming from, and then you'll be prepared then for that quiz number 3, okay? I know many of your on-ground classes, because as I said, I used to teach on ground, I would give a quiz at the beginning of every class. We have opened the quizzes for online to be given during the week at your leisure, but we are now giving them in class. That is a change, and the attendance is a change on this semester. Your exams, again, are through ExamSoft, same way, no different, still on Zoom, still during class time. And yes, we will be giving classes after the exams. and I'll be able to either give you a Kahoot where I cover all the concepts you need to know, or I'll be doing the PowerPoint. We'll see where the time leads us and what I can do at that point. Exams is only one attempt. Now, sometimes you're taking an exam and the power goes out and you're stuck. Don't be worried, because once you do the questions and push next, it's saved. So even an exam that you can't download, because I've had students go, oh my God, it's not downloading, what am I going to do? Well, 3 days later, you can go back and retrieve the exams. Not a problem. We can still get it. And I can see with the questions where you had the problem and when your internet went out. And then we can resume that at another time. Okay, so if something happens during exam time or quiz time that your internet goes, you can't get in something, please immediately send me a message in Canvas. Okay, that time docs is that time documentation that shows me and the dean, because she checks, to see that you did stop your exam at that time. Okay, so any sort of technological issues, tell me immediately. And remember, just if that happens, stop and just let us know. Now, if anybody has accommodations that gets extra time, I need to know this week so I can set up exam times and dates for you. Because you get extra time, I don't want that time to go into what I'm going to do for class time. So please let me know, and we will make special accommodations for you. So please let me know. Now, sometimes things happen and you can't take the exam. Again, please tell me as soon as you know before the exam, okay? So that we can reschedule it for you, or it's going to be a 10% deduction. And I don't want anybody to get a 10% deduction because you didn't communicate. So again, I'm telling you, communication is your biggest thing here with me. So again, Zoom, proctored, I'm going to look at your IDs. Make sure that you do have a whiteboard, okay? Not a piece of paper. If you don't have a whiteboard, go to the dollar store. They have them pretty cheap. Or take a baggie, a big quart baggie, put a white piece of paper in there, the magic dry erase marker, that works too. I've seen students do that, it works. So whatever works for you, please. I don't want piece of paper and pencil. Missed exams, as I said, if you miss it, no communication, it's going to be a 0. You miss it, and I've got communication before, we will work with you, okay? With or without a penalty, it'll depend on you communicating with me. Again, tell me before, don't tell me after. Very, very important. Again, document it. Any problems, please, again, talk to me. Homework assignments. So number 1, your syllabus is your Bible. I've set everything up with it. Make sure that you look at it. And I also, again, will be sending it in the announcement, what is due what week, so that you know. I do have one of those little things that you put on your desk, and I write on it the weeks and what's due. You want it digitally, you want to set your timer in your phones, whatever it is, just make sure that you are organized. It's going to get pretty hairy, as I said, around week 7 and 8. There's going to be so much due. You're going to forget discussion questions. You'll understand when you get there. So try to work as closely to the schedule and have those little extra things there, like NCLEX questions. You can get them done. And you can do those NCLEX questions over and over again until you get the grade you want. You do not need to remediate NCLEX questions. Just give me the questions. Make sure with those NCLEX questions, you follow the modules and what it asks for. I'll warn you, week 1 is on growth and development. It's not in the pediatric section of Saunders NCLEX questions. It's a growth and development section. And it is 50 questions, and please submit it in the format which we're going to show here. All right, we already know late work. So you go into NCLEX questions, it's going to tell you what it's due, what we want to have it on, and you need to take and save it and then post it up into the modules, okay? If I see that you're only sending me this little green square type thing, which I've had it done many times, it's always 1 or 2 every semester, I will send you instructions. I'll attach it to that area in your NCLEX question so you can see. And if you don't know or understand that, you can ask a fellow schoolmate or ask me. I'll come on Zoom quickly and let you know. I don't keep people on Zoom for hours, okay? If you need just to know how to do it, I'll quick show you and you can be on your way, because I know your time is as precious as mine is. Again, get whatever score you want on the NCLEX. Again, they're worth 5% of your grade. So each NCLEX question, 50 questions is worth 1.25% of your grade. And that can add up quite quickly. So if you have all hundreds, it's going to bring your grade up really well, because that's 5% of your grade in the end. Case studies, make sure that you go through your modules, and it is 1 attempt only, okay? So do the best. Now, I open these up the week before. Like this semester, week 3, you have Burns due. It will open next Monday, week 2, and it will go till week 4. It'll be open. Remember, it is due on week 3, that Sunday. That's without a deduction. If it's later than that, you know, that 1 week later, it'll be 10% off. Now, what if you get a 0 or your score doesn't show? What I want you to do is immediately send a help ticket and let me know. So I can see, I can look, I can problem solve also, okay, to make sure that you're getting the grades that you need on these case studies. Again, case studies are worth 5% of your grade. So that's basically all I ever said there. Okay. Papers, discussion posts. As I said, make sure that you do them. The discussion questions, do them with APA, put your references in the pediatric assessment project. Make sure you follow the rubric so you know what's going on with it. And as I said, you can start submitting this early and I can review it and tell you what you need to improve to get a better grade. And I do it this way because you're associate degree nursing students. You know, many of you do not have a previous degree. You've never worked with APA. And I think if I allow you to turn it back in, what I'm doing is I'm teaching you how to do this, because many of you will go on for your BSN and MSN. I'm sure many of you want to be practitioners. I already know that. So please make sure that you just send it to me early. So if it's due on Sunday, you know, of week 8, if you send it to me the week before, I can say, oh, change this, this, and that. But if it's given to me on Sunday night, there'll be no changes and you can't improve it. And I don't want that to you. I want you to get that A, that 100 that you possibly can, all right?
I have a question.
Yes, ma'am.
So when you say send it to you, do you mean like submit it in Canvas or like email you a copy?
If you're doing it early, send it to me as an email. If it's on week 7 or 8, you can put it in the Canvas. Thank you, Elise. Very good question. Yes.
Thank you.
And then I could say, hey, I see this, you should do this. Sometimes I even take papers and we'll redo them and put them in format just to show it to you so that you know from future what it should look like, okay? I know that when I started back at school, when I was one of those crazy people that age 53 decided I want higher level degrees. I had an associate degree nurse for 31 years of nursing. I didn't need a higher level. And then all of a sudden, when you have Magnet coming out and all of these different associations, they want nurses to have higher levels. So I always wanted to be a practitioner, but because I have rheumatoid arthritis, I knew that I was not going to be able to be the practitioner. I knew that, you know, my other love was teaching. I needed to be a teacher. So I did my BSN, and the first day of class, they talked about APA. They made me buy this book, the American Psychology Association, or whatever that book says. I'm like, what does this have to do with writing? I was so confused. And I had to write little notes down on how to get APA done. I didn't get it. I mean, you guys are younger, you can go in, you'll research. Purdue OWL is amazing. You can make your references and whatnot, but I know how confusing it can be. So if I can help you a little bit, I will, because I've been there, I've done that. So we know that quizzes is going to be through Canvas. You're going to come in the last part of the class for week for exam quiz 1 and 2. Okay, so make sure that you come to class next week. Be ready that there's going to be a quiz in the end. Okay, and as I said, they're all new this semester. Specialty exams will be done according to your campus, which means I have no control. There are, last semester, we had 2 out of 16 campuses that did ProctorU. Okay, most of them did it in on-ground setting. Okay, when is it going to be given? I don't have control on that. So they usually will be getting out that information, at the, in a couple more weeks. And any questions, go to your dean, assistant dean, and they can tell you when are the HESIs going to be scheduled, okay? I will tell you that because of the way I teach and the way I update my program every single semester, students on the HESI score well above 900, most of them. So if you do what I'm telling you to do, come to class prepared, listen to lecture, do the Kahoots, come to the reviews, listen to the reviews, do well on exams, and then I have a big 100-question Kahoots for the HESI, you are going to do well. And last semester, I started what we call a question answer forum. And I think that helps students even far better. And again, made you think, and I could really see how you think. It was like a very back and forth session. And I enjoyed it. I think we went on, and usually exam reviews are about an hour. I was almost an hour and a half or 2 hours with it. And the students absolutely loved it. And students from all different classes came to me, and they did well. And some of them really needed to pass their HESI, and they did well. So we'll get you good on the HESIs. I will be guiding you through it, because I know most of you was like, I have never done really well on a HESI. Well, I'm going to give you your first 900 or higher. As long as you work with me, you're going to get it. Trust me. It's the same sort of remediation mandatory that you've got to do after it. I do let you know where you are in your hours. I do not post HESI grades on the grade book until your remediation is done. So, and I usually go over going into campuses a couple times a day, trying to figure out, did you get it done? And if it's getting close to the end, again, you're going to get messages from me. Remember in exams, that you have to be on camera. One thing about exams is I have a quiet atmosphere. Once I start that exam, nobody's to speak over on Zoom. There's a chat box. We're going to talk there. I can handle anything you want on that chat box, and it keeps it a quiet environment for everybody. I know if I'm sitting there thinking about a question and somebody talks like, I'm going to jump and I'm going to forget what I'm talking about, thinking about, and that's going to be the end of it, and maybe get the question wrong. So that's just courtesy for everybody else. And I've done that since I've started, and I've had no problems, even with some really crazy sort of things that go on trying to get you into ExamSoft. Again, this just talks about, questions. Our course and our philosophy is based on this. If you're a nurse, you have certain treatments, certain things you got to get done, and they have to be done in a certain time or date. We're the same way with our assignments. If you don't get your assignments done, how are you going to be as a nurse? And that's why we have these late policies up and whatnot. And then, of course, having a charge nurse, a head nurse, whatever they're called today, you're communicating with them on that person. So communication is key. So we're sort of, in a way, teaching you how to be better nurses in the long run. Okay? That's okay, Morgan. We got you today. All right. So any questions so far? So we know attendance is important, that you must be here on time, or you're going to get some time deducted, which you don't want. Again, any time deducted, if you start getting a little bit up there, we will let you know. They'll be sending you messages, and I'll be sending it to let you know. Again, takeaway from this, good communication. Talk to me, I can help you. You don't talk, I can't help, okay? Now, let's go into our first week's PowerPoint. I sent this to you yesterday so that you would have it. I also sent you the 2 handouts. It was on vital signs and it was on Erickson and all the theorists. Now, pediatric goes into theories and on how children behave. And you're going to see a lot of questions in quizzes and exams and HESIs, all about theorists and what does it mean. So, today I'm going to hit on some of those things. But as we go through next week, we're going to go through infants and toddlers and preschoolers, and I'm going to go over that stuff. Now, I want to warn those of you who have children, do not look at your kids as for the answers, because the books are completely different. And I'll give you one example. One of the textbooks says about gross motor development that a child should be walking by 12 months. Well, you have some children walking at 6, 7 months. My children, my grandchildren never walked till 15 months, and they never walked, they ran. That's just one thing. Teeth growing in their mouth. They never had by 12 months teeth, and they should have 4, okay? Never. But again, 15, 16 months, they got 6. So don't relate pediatrics to your children. Forget you have children or children. And I think actually students who don't have children learn better with this, okay? So remember, it's from the book. Now, as you go on for upper level degrees, you're going to be doing papers and research on healthy people 2030. Now, when I started into nursing school back into my BSN, it was 2009. So we were doing 2010 healthy people. So now we're up to 2030. And 2030 is a government program that looks for specific things for environments that need to be looked at. These are children and elderly and homeless, et cetera, et cetera. What can we do to help them? I mean, you've heard, these school lunches, healthy eating. You've heard Obama about getting up and playing outside and, 30 minutes a day or reading books. I mean, they've all had their own, but these are now what we're looking at. The family, supporting a family, because remember, nursing with pediatrics is not just a child, it's a family. So one of the reasons why many nurses don't go into pediatrics is because they have to deal with a family, and it's mom and dad, and they can be pretty rough sometimes. I was that nurse that always got those difficult families, and I was able to handle them because I put them to work. And that's what you do. Let them be your ears and eyes, teach them what you need to do. And let me tell you, they'll be the best eyes that you can have. Development, making sure they develop well, mental health. Children do have mental illness, and I've seen severe mental illness. And I'm not just talking about a child who may be autistic. I'm talking schizophrenia, where they really do see and hear things, and 6-year-olds. So they have it. And the biggest thing with children is nutrition, nutrition, nutrition. The child doesn't eat well, they're not going to grow and mature, cognitively aware, and they're not going to be where they should be, because food feeds the brain and the muscles and the nerves. Can you imagine an infant born at 7 pounds? They go from not being able to lift a head to 1-year-old where they're walking or running, and they triple their birth weight. If they don't do that, can they be able to do all this cognitive awareness and now drinking in a sippy cup and building blocks and all these things? No. So nutrition is so important. Having a healthy weight, too little, too much, both are there. Physical activity, like I was just talking about with President Obama's wife, was all about that. Oral health, if your teeth aren't good, they're going to hurt, you're not going to eat. So oral health is important. Healthy sexual development, this gets into adolescence. Always in every area of people, it's always safety and injury prevention, especially the young kids, right? But especially the elderly too, because you know what, they're tripping and falling, etc. And then what's out there in the community. Some of the problems that we see is obesity and type 2 diabetes. This is a lot because of the electronic age. Children like to sit at home on their iPads and, playing all the new games out there and, watching TV and movies, and they're not out playing where they should. And they're just sitting there, and it's fast food all the time. When you have two parents working, it's hard to feed children proper meals every single day. And it is a choice that's being done. And it's no fault to anybody. It's just life. So, but just making sure that these children aren't overeating. Childhood injuries, we call these the unintentional injuries, and most of them are motor vehicle. That's the highest level of childhood injuries, at those motor vehicles, whether they're in the seat, strapped in the seat, or ran over by a car. I've seen many children ran over by a car in my career. I've seen some that have done poorly, and I've seen some that walk away. So it could be either or. Violence, whether it's bullying, whether it's, the adolescents and gangs. Vaping is a big thing that's newer. And of course, your mental health I've mentioned. And here's just some pictures that depict some things. I mean, swimming. I mean, most of us live in Florida. There's a lot of swimming. I've got a pool in my backyard. I've got a 6-year-old grandson. He turned 6 on Monday. And I taught that kid by age 2 how to do a front flip in the pool and how to swim without swimmies. And that kid will not, even today, go in the pool and say, Nana, may I please go into the pool? Because I want to watch, because accidents happen. And he understands why. And I taught him safety from the beginning. So, and of course, guns, suffocation. I've got an older brother who pulled a grease pan off the stove and was marked for life. His arm got all burnt up. So, and of course, taking grandma's pills. And you know what they like to eat? Flintstones vitamins. They just love those little gummy bears, and I like to get in them and chew, chew, chew. It's when they get into the Tylenol and the Motrin when it becomes a fear. Health problems, the highest at risk are those born very small, whether it's very low birth weight or low birth weight. Those children are born with a lot of problems with their lungs and nutrition. Their skin is not completely made. It's very pink and you could see through it, and up for all sorts of sepsis. Children that attend daycare. I call daycare the area where children, they swap spit all day long, don't they? From one toy, from one kid to the next kid. And you can't prevent it. It's just a fact of life. And what they're doing is they're just spreading their germs around. And that's bad, but it's good because now they're exposed to these germs. And now by the time they get into kindergarten, first grade, they've already built up the immunity against them. I think children that first go to daycare, they're almost sick every other week, and it's hard for parents. And I'm very aware of that, but it's actually pretty good. Living in poverty and homeless, I mean, it's a reality of life. How do these children eat proper meals? Do they get the right fruits and vegetables? They're poverty or homeless? Probably not. They're eating whatever they can. So that is a problem. Chronic medical, psychiatric illness, disabilities. Do they have all the equipment they need? Do the parents have the proper teaching? Have they taken care of their child the right way? And there's always barriers to adequate health, dental, and psychiatric care. I know that in my population down here in South Florida, there's a lot of migrant workers. There's a lot of farming that goes on down here. And I know the Mexicans down here, if I see a mother with a baby or child that looks sick in her arms, that kid's going to be the sickest that of all the children there, because they're afraid to come for help, because many of them are afraid to be deported. And they're say, I don't have insurance. And they're just scared. So there are barriers. What about if they need a $5 copay and they don't have the $5 to get there? Or what if they don't have transportation? These are real problems that parents and children have. Infant mortality. So infants are considered neonatal up to 28 days of life, and they're infants from after that up to 1 year old, and that's the description of them. So we know that the first area, the younger children, are the highest level of mortality. And the one thing that surprises me still to this day is that the United States has more deaths of infants than do many other countries. And we think we're like this country that is far ahead, and we're not. So there's a lot of things have been done. I've seen a lot of changes done, improvement in care. I've seen, for instance, cardiac care, where some of these children with some of these diagnoses had no outcomes. They would send them home with liquid morphine to die because there was nothing to do for them. And today these children are living and living full lives. So I've seen a lot of changes, but more needs to be done. I mean, a child who's born at a low birth weight is the highest level of infant mortality. Now, as they get older, we've already figured out what they have and been treating it, so it is less. And then from ages 5 to 14, they've got more common sense, and they're starting to be more careful with things. As they get to adolescence, all of a sudden they're adults and they get into some very crazy activities, and they press themselves to do things where maybe they wouldn't as a younger child. The injuries, homicide, suicide, firearms is a big thing. And suicide, it's all about depression and body image. You know, body image is a huge thing, and we'll go into that on week 3. Increased mortality, I've mentioned it: homeless, poverty, low birth weight, chronic illness, foreign born. We don't even know what's going on with some of those kids. And again, daycare, only because it is the spread of disease that can happen. Now, as I mentioned before, pediatric nursing is a family-centered care. It is the child at this point, especially younger ones, all they know is the family, so that they recognize the family as the constant in their life. It is that one thing they know they can predict, okay? What gives them their cultural, their emotional, it gives them their health, all different health. So family is very, very important. So when we take care of a child, we're taking care of a family. What is a family? Well, a family is whatever they say it is. You know, when my grandson was born, it was grandma, grandpa, and my daughter and the baby. I mean, now he has mommy and daddy, and you know, that there it is. It could be 2 dads, 2 moms, a mom. It could be 1 dad. It could, whatever it is. This is a family. So whatever they say it is, that's what the family is. Now, pediatric nursing, you are going to be a counselor. You're going to be the psychologist. You're going to see relationships between moms and dads, or moms and moms and dads and dads. And, you know, you're going to sometimes get in between those things, you know, and it just takes a lot of listening. Okay. I think that the biggest role is us teaching and letting them know disease prevention, health promotion, and teaching them about what's going on. And of course, injury prevention. So we know that we have to look at these children and these family, figure out what's going on sometimes, and then take action and make sure they get what they need. Now, many years ago, we didn't think about children and having pain. We really didn't. So today, we know that children think, especially young ones, they go to the doctor, they go to the emergency room or urgent care, whatever. There's somebody's going to give them an injection, right? A pinch, what they call them down. They're going to give me a pinch, or give me a shot. I don't want a shot. And they look at you as a nurse and they run in the opposite direction. I've had children walk into the ER, see nurses, and they run out into, you know, the parking lot, and we have security chasing them because they're so afraid. So today, what are we doing? We are trying to promote a traumatic care. That means giving the least amount of pain as we can. Now, for my PhD, I did a project, and it was all about school-age children attitude and behavior towards injections. Now, I think pinches, shots, needles are one thing that children are afraid of. So I asked children, why are you afraid, or why are you not? And one of the things I developed was a program called Huggies. And it's not the diapers, it's H period, U period, G period, et cetera, et cetera. Help us give great injections efficiently and safely. And what I proposed, and I did research on, was that a child who was held by a parent before, during, and after an injection had less pain and stress and fear, as evidenced by less crying, because they're in mommy's arms or daddy's arms. Now, I might have another nurse hold the leg if we're giving it into, the vastus lataris, right? So to prevent any sort of jumping or jerking, but these children did so much better. In fact, that program's still going on at Nicholas Children's Hospital today, and probably will continue, because it feeds into their theorist, which talks about comfort care, because it is a parental comfort holding position. Let you hold the child. And I propose that for doctors' offices everywhere, and more healthcare providers are starting to do it. They realize it's better than taking a kid, laying them on the stretcher, holding them down, and jamming an injection into their leg, right? I thought that was barbaric when I saw it, when I went into the emergency room, started doing that. So again, it reduces psychological and physical distress, because now we're giving comfort. We're not giving just pain, right? And let me tell you, when they not tensed up and stressed, it's not going to hurt as much either. So let's talk about family, social, cultural, whatever. Now, as I said, the family is all different sort of families, like I said before. Now, one of the things that we need to understand is who is the boss in the household. Different cultures have different people. I've learned that the Hispanic people, if there's an abuela around, usually the abuela is the one who talks for the mother, because usually that's the one who babysits that child all the time. But there's other ones that you need to speak to the father, and you need to respect those cultural differences. So if I don't know, I'll say, okay, who am I going to talk to? Who do I need to teach? And that will give me an opening to understanding, how do I work with that family? And it gives them respect for me, because I respected them first. As I said, you need to understand that social, cultural, and religious differences. It makes a big, big difference that's going on, how you take care of them. We know that there are certain things that affect a child, and it affects how they treat or can treat their child. Their race, ethnicity. This tells me maybe there's some diseases that are according to race. Just think of what? Sickle cell, right? It's of the African American. So poverty, maybe they can't get medicines, maybe they can't get treatments, maybe. So what would I do? Well, I'm going to have social work, or maybe the insurance people, talk to them in order for them to get the things they need, because most states have programs to take care of kids so that they do get the medical care they need. Also, we need to respect their religion or spiritual identity. It could be where some religions that a female patient cannot have a male nurse taking care of them in some cultures. Or when we are doing assessments, not to just undress them, do pieces at a time and keep them unexposed, okay? Or giving them time to do their little religion or spiritual things that they need to do, because that makes them feel better. That's what we need to do, is respect for the patient and the family. So you have migrants, like I've just talked about. So a frequent health problem of migrant children and adolescents in the United States is what? What would you think? Anybody?
From the C.
See,
Tuberculosis, yes. And tuberculosis is because they don't have all of the immunizations like we have, or testing for them. So it is something that can happen. The other things, yeah, there's some of it, but mostly it's tuberculosis, this transmittable diseases. So again, be aware that there other people think differently. Now, I know that I came from a very small town, had no other cultures, Black and white Americans. That's what we were. Small town USA in New York. There was no Hispanic. I don't remember anything else. It was that type of area. So when I came to Florida, back at 1980 is when I come down here. I graduated nursing school in 76, believe it or not. I'm an old lady. Yes, I am, whatever. So anyway, I come down here and I had to learn, people think differently. And I never thought of that way. We weren't taught to think of this, in nursing school back then. It was not, cultural care, but we do now. Now, as I said, keeping clothing on and stuff. Special foods, how about those cultures that are only vegetarians, or they don't eat pork, or they only eat certain things? We need to be aware of that. Well, we need to tell the kitchen, right? They're going to send up a tray to send up the right things. Can you imagine if your culture didn't like to have meat on a tray and they sent up roast beef? You would be offended. It would, like they know what's going on here. Also, giving them those chance to do the prayers, whatever they want, and respect them, and then have them work with your schedule. I need to do this treatment, this procedure at this time, so can you be ready for me then? Does that work with you in your guidelines? And if you work with them, they work with you very carefully. Another thing I found out here is I was working, I'm an adult and a pediatric nurse, very unusual thing. But I did half my career in adult ICUs and management, etc. And then I went into pediatrics. And when I was an adult nurse, I was in the surgical ICU and I was pregnant at the time. And there was this patient who this family wanted to do something with chicken blood and all different things. It was crazy, but because I was pregnant, they made me tape a quarter to my belly button so the evil spirits wouldn't get into me. Now, it doesn't hurt me to do it. What they wanted to do was not bothering with any medical care, so I did it, okay? Crazy thing, a day later, this patient started to get better, and that was a very, very sick patient. And I'll always remember him because I was the head nurse of the floor. And I actually came down to check on him. And when he came back up, he was teaching me Spanish and I was teaching him English, and it was pretty neat. But it was some sort of evil spirit thing going on. So, but I respected it. Another thing I found in the Hispanic population, they believe a fever, you need to cover them up. So you'll get children with a fever of 104, especially the small children. They'll have hats on, they'll have shoes on, they'll have socks on, 3 onesies wrapped in a big blanket. And the first thing I do is, let me take this off, hats off, socks off. And I'm saying, okay, but I explained what I was doing. I said, if you have a child with a fever and you cover it up, how's the fever going to get out and go away? So when I explained it in that manner, they got it. Now, the next thing I found out is they don't like their children or anybody walking on the tile floors with socks on. They have to have socks on. And I'm like, if a child has a fever, take their socks off. Let them walk on the cool floors because it will pull out the fever and help the fever come down. That's that hot, cold thing going on there. Have you ever heard, don't go out in the rain and get wet because you're going to get sick? Or don't go to bed with wet hair? All of these things, you're going to hear them. And there's some cultures that believe in it stronger than others. So I just make sure that I describe these to those that I think maybe, because a child with a fever feels horrible. A kid that got his Tylenol or Motrin, in 20 minutes, the fever's gone. They're running around and acting good, but they're drinking and eating. And that's the important thing. So let's do all the things that we can do to keep that fever down where it needs to be. Religious beliefs and practices. I think the biggest one that I can tell you about this is having a child in the newborn ICU, premature, requiring a blood transfusion, and the family is a Jehovah's Witness. Now, Jehovah's Witness to believe that you're tarnishing the soul of the child or them by giving them blood. And they don't believe in it. So you cannot get them to sign a consent. And I would never make them do it. But the child will die without the blood, okay? So what do? Well, we've got risk management and our lawyers, et cetera, and we get a court order. Now, I get the order, I can give blood. I am not going to take the blood out and put it in front of these parents' faces. Absolutely not. That's total disrespect on my part. So I'll either have them step out of the room, or I worked night shift for 22 years. So I would say, when you go home, I'm going to give it. You can call me at this time, I'll be done, and I will let you know how your child did. Or in the day shift, have them walk outside, put everything up, get it infusing, take the blood bag, anything with blood, hide it, put it away, and cover the tubing, everything with a blanket. So they didn't have to watch it. Now, you think that's something that, yeah, I want to tell you. I met one of the last days I worked in the emergency room, I met one of my cardiac boys who is now 18 years old. And I noticed the name, and then I looked at the history, and I'm like, I know this kid. And I remember giving him blood twice. I went into the room and I said, oh my goodness, he's gotten big. Do you remember me? And they go, Betty Boop, because my name was Betty Boop as a nurse. You're going to remember that name. And that's important, because how many nurses do you have in a 30, 40-day visit, right? That's Boop. I'll get Boop over here. Come here. Anyway, she hugged me and thanked me for being so respectful for her, and always being good to her boy. And this is 17 years later, you know, so it does make a huge difference that you respect a person's belief. I don't have to believe in them. I have to respect them, okay? So again, we're supporting, we're counseling, you know, and we're just giving great information. And of course, we're going to do the most evidence-based practice we possibly can. So, leading cause of death among African American boys ages 15 to 19. Which one? It's a teenager.
C.
Firearms, absolutely. Yes, very good. All right, let's go into some growth and development. Now, as I said, an infant's born, right? They can't lift their head up. First thing they do is they lift their head up, and then they roll from front to back to front. Then they get on their knees and they crawl backwards and forwards. And they get around the couch and they crawl around, and then they walk, right? This is that level of growth and development. And we're going to go over that more next week. So we know that this is interrelated, simultaneous, and ongoing. And it doesn't mean that they go through every step. There's some kids go from crawling to walking. You can't predict it. As long as they're going forward in the maturation and development, we're doing good. And remember, these children, every time we see them, we are assessing them for their growth and development, whether in an ER, whether in a doctor's office, well visit, sick visit, we're looking at these things. So this just grows about growth, is getting tall, and development is that movement, those things they do, you know, using their hands, cognition, making a rattle shake and hearing the rattle shake. And this is all cognitive. And we're going to go into more of this a little bit more next week to show you about it. Stages of development, what are they doing, those tasks, whether it is, you know, a voluntary palmar grasp to a, you know, reflex task to a voluntary to the little pincher grasp. These things are tasks that they do. There are fine motor, which is all fingers, and there's gross motor, which I call get up and go, 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 like Paw Patrol, right? That's gross motor movement, okay? Fine fingers. And then gross motor is all get up and go. It's directional, it's going up, it's that sequence, as I said, lifting the head, turning front to back to front, and then it's hitting those developmental milestones. And these are some terminologies you'll see in your book. They're on the beginnings of the chapters. So look at them, you're going to see them use these words. And again, I do them again next week. As they grow, things changes. That's why you got the vital sign sheet. A newborn infant's heart rate, 140 to 160. At sleep, normal, resting. Respiratory rate, 40 to 60. But a 1-year-old, might be 100 to 120, and it might be 30 respiratory rate. Why do we need to know those things? Well, what if you're giving a drug like digoxin? When do you know the pulse is too low? Or when do you know if it's too high? When do you know to intervene, right? So these are important to remember. Those vital signs, think of the age of the child. How does that vital sign fit into what we're looking at? As they get older, they regulate their temperature. I mean, babies are born. What do we do with them first? We put them under a warmer. Why? They do not regulate their temperature at all. There's nothing to hold in the heat. It just goes. Put a hat on them right away, don't we? And we put them on that warmer to keep them warm. As they get older, they're going to need less and less clothing, and they can tolerate it a lot better because they're going to get bigger and have fatty deposits, et cetera, et cetera. Sleeping, we know infants, they sleep, they eat, and they poop, and they sleep, and they eat, and they poop, right? That is all the time. They are resting most of the time. Again, nutrition, nutrition, nutrition. Single most important influence on growth. We know children all act differently. You've heard parents say, you know, my first kid was a breeze, but the second one has given me, wow, a real rough one. And they're all different. And I think a lot of it has to do is how they're treated as infants and how we respond to them quickly. And there's just some kids that don't want to go to anybody, right? You have some kids that'll go to everybody and some kids that are afraid of everybody. All children are all different. And I think it's why I love pediatrics so much. I really have to think. Now, these are your theorists that I was talking about. We have Freud, Erikson, Piaget, and Kohlberg. I'm just going to discuss a little of them today, but these are ones that I'm going to discuss in each area: the infant, the toddler, the preschooler, the school age, and I'm going to tell you how they grow and how it changes. We use all of them. I've not seen Fowler in anything that we use, but it is mentioned. Freud is all about oral, anal, and phallic. You know, the one thing I'll tell you about Freud, it's sensorial motor. It's like everything touches, has texture, and then they explore the world through their mouths. I mean, how many kids always have something in their mouth? The pencil, toys, they're always biting and chewing on stuff. That's why, you know, there has been this off and on pacifiers for as long as I know. Well, they finally realized that these non-nutritive devices or a pacifier literally are that self-soothing, stress-relieving things that they can suck on a pacifier and calm themselves down. So oral and Freud, very, very important stage. This is Erikson. I'll just mention infant just to show you what we'll be talking about. You know, infants are born and they either trust or they mistrust. How do they trust those people who take care of them? Well, all their needs are being met. They cry, somebody gets them. They're hungry, they need to burp, they want to be held, they need their diaper changed, they're trusting. Those infants who are on mistrust are those infants are not picked up right away on a consistent basis. So mistrust is that more child from a family that maybe has too many kids, or maybe they have other socioeconomic issues going on there. But trust is that kid that's going to be that nice, calm kid. Piaget is all about thinking, as in sensoromotor. This has to do with seeing something, feeling it, and maybe taking a rattle by grass, shaking it, and hearing that, and going, oh, I like that, and then doing it again. So they figured out the rattle's got something that makes a sound. So that's about Piaget. We're going to go into it more. And Kohlberg. Now, Kohlberg talks about good and bad and a consequence for each. And we're going to go over different levels, the pre-conventional, conventional, and it talks about where are their cognitive thinking at that point about good and bad. Another thing that you know kids do is all they do is play, right? They're always touching, feeling, playing with something. And we know play expands their minds and gets them thinking. And you'll see here little kids as they get older talking to themselves and making noises and flying airplanes and hugging dolls and having them coo and talk. And it's quite incredible to hear the imagination going on. There are different names of play. We're going to go into that more next week, but as you do the reading, look at it. We know that it develops everything. I mean, this little boy down here who's gobbed himself and everything, it was actually, he's feeling is that texture and putting it everywhere and getting satisfaction from it. And then realizing he did get it everywhere. It's not going to happen initially, but if he does it again, he's going to have mommy upset again, right? But it's all about being creative. And there's different types of play. Well, most toddlers are in parallel play. They play next to each other, maybe with the same things, but they're playing next to each other. They're not interconnected. Solitary, of course, is alone or they're watching someone onlooker. Associative play is they're playing together with the same toys, but there's no goal to their play. Now, cooperative play is as they get older. This could be they're going to play a game of checkers. So they're playing together, playing a game, but there is a goal. There is an outcome. Somebody wins. And that could be like a board game, like checkers. Toys, what they do is you put them in front of them. They're going to try to crawl there. It helps them moving, pulling, all of those things that, with development. And I think this is a great thing that says it offers an opportunity to bring children and parents together. You're sitting there rattling the little thing and talking with them and playing music and singing and all of those things. And that child's going to sit there and coo and smile and laugh. So developmental assessments. Well, number one thing you need to know about any time you go into a child is you must go in on their developmental level. You can't go into a toddler and expect to put a blood pressure cuff on their leg and for them to sit still. They're not gonna. So you're gonna go in there to a toddler, maybe sit next to them, maybe give them a little, I always had stickers in my pocket, girls and boys stickers. Or I would go, oh my goodness, look at those big blue eyes or curly hair, or, oh, your sneakers light up, something. I'm telling you, 1 year old children understand what you're saying. So now they start to trust you, okay? Then you let them touch and feel the equipment. Then maybe they might do it on me first, maybe push the button for you. And then you're gonna get something, a result that's accurate. If you try to do it without getting on their developmental level first, it's not gonna happen. And you're not gonna get what you need. So taking 5-10 minutes will save you time in the long run. And they're not going to be afraid of you when you walk in the door, because now you're the fun person. You get to play. You know, I always say that working in the pediatric field allowed me to go to work to play every day. And that's what I did. I went and played with the kids every single day. Children are born with all different sort of things. We're going to go into a lot of them more. I mean, here's some cleft lip, cleft palate. It could be due to many things, syndromes. I mean, I think every person, when you talk about a syndrome in a child, you think Down syndrome, right? That is one of those type of genetic things that can go on because by meds, drugs. It could be caused by many different things. Could be caused by chemicals, could be rubella, you know, get next to a pregnant woman. And then of course, those chromosomes can be something going on. So if we understand genetics and like a Q22 deletion syndrome, you know, I know that's the George. Now, what do I need to know about that? How does it affect the child? What do I need to do for the child? And because I understand what that says, I'm able to do that. And I'll provide that education to the parents. And as the child gets older, to the child. And the other thing is, you have a child born that wasn't born normal for whatever reason. That parent's going to, especially mom, she is going to be hormonal post-delivery, especially newborn, and make them realize it's not your fault. It wasn't that glass of wine you had at 3 weeks in the pregnancy, because many parents blame themselves. You know, especially those cardiac children I've seen. I worked in that area for 10 years, and you could see them. I did something wrong for the baby. So if you can, getting that child, putting it in mother's arms, let them have that bonding, very, very important for them. And that does promote that attachment. And again, therapies that they need, making sure that they understand what they are, what they're used for, and making sure they get it at home. Now, I'm not going to go into this question completely. It's just opening your mind to these terms. A father tells the nurse that his child is filling up the house with collections, seashells, bottle caps, baseball cards, pennies. The nurse should recognize what? Well, let's go into the answer. Now, there's concrete operations, pre-operational. This is all cognition. This is Piaget. We're going to go into it next week to understand more. The one I really want you to understand is object permanence. You ever see a kid that you put away a toy and they go to the toy box and pull it out and get it? Even though it's out of sight, they still know it's there. Infants know that. Let's say you have a little rattle that they want to go get and shake because they like the noise. They know to look underneath whatever there to go find it, right? Objects permanence, even though they can't see it, they know it's still there. And assessing children and whatnot. I mean, HIPAA doesn't matter what age patient you have, does it? Always protected. I mean, today we're on that age of so many different computers. I mean, you have rolling computers going into each room. You have computers in every room, you know, to make sure that we close them down before we go on to the next child, because they will go and look through it. How do you talk with parents? Now, sometimes you only get one parent bringing the child in, so it's easy. You know how to, talk with them. Number one, I have learned, especially with the population here in South Florida, I mean, before COVID, I might have 6, 8 people in the room with one child who came in with a fever. And I'm like, okay, who am I talking to? Who knows the history the best? And it may not be mom, it may be the aunt, maybe the grandma. So making sure that person has all the accurate information. Or they're going to keep asking, so is that what it was? Yeah. And that was it was? Okay. And when did you give that? So talk to the person you want. Now, one of the things with children, parents tend to want to tell you the history from birth. And if a child is 3, 4 years old, you don't need to know from birth unless it was newborn birth and they still have respiratory issues or something of that sort. You want to know, why are they here today? What is going on? And any past medical history that will make a difference on today's care. A lot of times you need to sit there and just listen. Remember, some cultures, you can't look in their faces and their eyes. Be very offended by it. Sometimes it's the father you look at, not the mother you look at. Or maybe you have to include sometimes grandma, abuela, into the group, because then you haven't offended anybody. One of the things I have found, especially in the younger infants, parents have a kid who's come in, they're sick. They've been to the doctors twice, they've gone to urgent care, the kid's been sick, they've been working full time, and they finally get to the emergency room and they're exhausted. I have made it a point that when I see a parent of a young child that this has happened to, that I'll say, wow, you've gone through a lot to get your child here. You must be exhausted. Well, you've done a great job. I said, you're fighting for your child. You've done what you're supposed to do. That's awesome. Let's see what I can do to help you today. And I'm telling you, you could see their shoulders relax. Like, I understood they've gone through a lot. And that empathetic moment really makes a difference in the care for them. If this child or this parent doesn't speak your language, get an interpreter. Never use a family member, because the family member will interpret the way they understand. So either get an interpreter or use that blue phone that most hospitals have. There's ways to talk, of course, especially with children. I always use play. I always will use play with things I'm talking about. and the children to respond to that better. And again, that play is on their developmental level. I've built up a rapport, and then they're going to tell me everything. And children, what I love, they don't lie. They don't over exaggerate. They tell you exactly what it is. You know, adults will tend to exaggerate things. Children never do. So again, you're going to get who the informant is and find out what's going on now. Find a brief history at birth. Of course, any dietary constraints, allergies, if they're on medications, have they had Tylenol, have they Motrin? And I want to know, especially if you have a young child with an upper respiratory, have they had their immunizations? Because I don't want to be exposed to things, because there are some parents who don't believe in immunizations due to religious reasons or whatever. So I want to protect me by wearing a mask in there. Because do I want to have pertussis? Oh, absolutely not. And these are things that we give immunizations the first year of life for that. As we get older, sexual histories, and you know, we can have parents removed from the room to speak to adolescents to find these things out. I wouldn't tell anything in front of my parents. I mean, they would be absolutely upset with me. So, but to properly take care of a child, you need to sometimes get them removed. And you do not have to tell the parents what they said unless it's something that could cause harm to themselves or others, okay? I like to ask how they're doing at school. I want to know if there's any habits, especially young kids. Do they like this pacifier only? Do they need to have this blanket? Do they what? I need to know that. And I'm going to be looking at that parent-child relationships. You know, walking into a room, many times I would see a room torn apart, and the parents are there on their phones watching TV, and they have got those black little ear things thrown all over, open the drawers, and alcohol wipes and tongue depressors and all over. And I'm like, okay, what's going on here? You can see they don't have control on their children, or there's not that caring that should be. I mean, most parents wouldn't allow that to happen, but I've seen it more than once or twice. How do they eat? Anything they need to eat? Any practices? All these things, as I described before. Are they overweight, underweight, at risk, whatever? Physical examinations on adults, you're going to do head to toe. Well, throw that out the door with pediatrics. You're going to do whatever you can do when you can do it. I'll give you an example. Have an infant who's asleep in mother's arms, and you need to do an assessment. I'm going to listen to their lungs and their heart while they're at rest, because I can listen to it and it will be accurate, right? And then we could worry about reflexes and all that other stuff going on there. So again, head to toe, absolutely not. We're just going to be doing what we can when we can. And, you know, children that are older, sometimes we have to let them do things to you first, to touch, to feel, do it on their teddy bear, whatever. So again, I've talked about those things. These are all the things we look at. On infants, we do apical pulses. It's more accurate as they get to be about 2. We can do radial pulses. Again, putting those blood pressure cuffs in different places we do. Sometimes children, they got these big bellies. Just looking at it first before we do any touching. I think we can see a lot of even respiratory distress just by looking first, inspection. I do have older kids doing reflexes. I might even have them do my knees to see my knee bounce up and tease them. I bet I can make your leg bounce without you doing it. And they just think that's just so much fun. Doing head, chest, abdominal circumferences are important depending on diagnoses. We know heads are born big when they're infants, but we know the head and the chest about 1.5 years should be equal, and maybe the chest bigger than their head, and that's normal development. And if the head's bigger, there's a problem. Is there hydrocephalus? Getting their height, you think getting a kid underneath that thing with that wood thing on their head is easy? It's not. They think it's going to come down and bop them hard. So again, let me play a game. I put me there and I put it down easily. I go, oh, this is my number. Let's see what your number is. Here, hold this. Tell me when it touches your head. Put it there. I said, oh, look at your number. You got a better number than mine. And now the kid's happy, you've got a good height, you haven't scared the child because they think it's going to smash them. You don't know what they think, so have fun with it. Putting blood pressure cuffs, they're size 0, up to adult extra large. 0, 0, 0, 1, 2, 3, 4, 5, 6. There's all different sizes, and we put them everywhere. I do like for the older children, even the younger ones, that are not going to tolerate it. I mean, blood pressure's in your arms. Doesn't it hurt a lot of times? So put it on their legs, and that you can hold their leg and, make it easy on them, and they will tolerate it better. And the last chapter is all about pain. Many years ago, we didn't work with pain. We didn't deal with children. We didn't treat it as well as we should. Children even won't tell you they're in pain because they're afraid you're going to give them a shot or you're going to give medicine that doesn't taste good. We know that we're giving doses to these children, and many nurses think that giving less than is going to work. Now, actually, morphine, which is a very powerful narcotic, we need to use it sometimes for different things. We have used 0.5 to 0.1 milligrams per kilogram, put it in a syringe of, let's say, 5 mLs, and slowly give it. The kids do really well with it, and we've treated their pain. But remember, it's just not that. We also need to do maybe positioning or some distraction, something to help them with it, and maybe giving Tylenol and Motrin in between. Now, pain, we know with adults, you say, on the scale of 0 to 10, 0, no pain, 10's the worst, how much pain you're in. Well, kids can't do it. What about an infant? They can't talk yet. So we need to do things. Of these things, the 3 things we do the most is FACES, Wong-Baker, and numeric. Numeric scale is used by the book 8 years and older. Now, have I used it on younger kids? Oh yeah, I have. These are some kids that are brilliant. What about FLAC scale? This is your nonverbal, could be a nonverbal 18-year-old cerebral palsy child. We can use it there, or we can use it on children up to 3 years old. At 3 years old, they can use FACES. They can point to a picture. But what does FLAC mean? It's what their face looks like. Are they grimacing? Their legs, are they moving, or are they just stiff because they're in so much pain? Crying, are they crying, and can you console them? And if you can't console them, they're crying, grimacing, and maybe they're stiff and they're not moving, this kid's in severe pain, and that scale is used quite well, and it works good. And as I said, FACES is preschool age and older. Preschool starts at age 3. So let me see, pain. Where do kids get pain? I think the biggest one that you see is earaches. Earaches hurt. And those kids come in holding their ears and just screaming, and getting them something for the pain. It's the first thing I'll do for them, even before the doctor comes in. Say, where do you hurt? And they'll take their finger and they'll point to their ear, and you just want to reach out and hug them. And what I'll do is I'll give them, if they haven't had anything, I'll give them some ibuprofen. And ibuprofen has a little bit of anti-inflammatory in it. And in 20 minutes, that kid is feeling better again. And that's the whole thing. We know that it could be surgery and all those things that could cause pain, so many things. But here's that nice scale of FACES. And they point to where they hurt. Little 3- and 4-year-old kids will point to it. And the best thing about kids, they don't overrate their pain. When they say they have a 7 to 9 or an 8, they have an 8. They just know it could get worse. So I always take what a kid tells me in pain, I take it for real. All different sort of pains we have, could be chronic, could be reoccurrent, sickle cell disease, that's always with pain. There's all different pain assessment tools, whatever hospital, if you work in peds, go and look for them. Remember cultural differences. I know that my Hispanic daddy with a Hispanic boy, he's in pain. Daddy will say, oh, you don't have any pain. Suck it up, dude. You're okay. No problem. And I'm like, Dad, he's fractured his radius and ulnar. I'm going to give him something for pain, okay? And the kid looks at me like, thank you, because he doesn't want to go against Daddy. But there are, what I'm telling you, there are some cultural differences. They don't have to deal with it. As I said, there's other things we can do to help pain. It's just not the medicine, okay? I think distraction is the best, especially your older children. Give them some crayons, give them some stickers, put on a video game, put on the TV. Music on infants is amazing how it works. I used to have the newborn ICU and cardiac ICU at night with music everywhere. And those children would sleep all night long because it was better than hearing the bing, bing, bong, bong of all of the monitors, right? How about repositioning, cold packs, hot packs? All of those things work. And this little premature infant, probably about 900 grams there, probably about 28 weekers. Those kids on the warmers or into the isolates, they are screaming. They're miserable. Take them up, put them on mom's chest. Their heart rates come down, their respiratory rate comes down, and they rest. And that is part of pain management too. As I told you, Tylenol, Motrin, use all of your resources, and put them in between if you need to. Also, things for pain, like this little girl's going to get her blood drawn and she's smiling. And why? That's EMLA numbing cream. So the area is numb. So she knows when they come in to draw the blood, she's going to feel them touching, but it's not going to hurt. It don't hurt me. I'm going to be a big girl, right? So things we can do to help. There's sprays, there's creams, all different stuff. These are all areas where we can have pain. They do circumcision on newborn young boys using a pacifier with sugar water. And Harvard neurophysicists said it works the same as morphine. They have proven it through research. So pacifiers, self-soothing, right? Mentioned it before, it works. My grandson had it done like that. All different areas where you can have pain. So, which of the following is an important factor for consideration in understanding the pain experience in children?
B.
Right, they're not going to admit it. Why? Well, number one, maybe it's Daddy's there and I can't tell them I'm having pain because I'm supposed to be macho. I've mentioned that. But what if they don't like the medicine? Or what if they're afraid of a shot? Yes, very good. All right, any questions? Did you learn anything today so far? All right, we're going to do our Kahoots. When the Kahoots is done, we'll be done. I'm going to be trying to get you out by about 10 after 5 every week if I can. We know that on-ground classes give you 10-minute break per hour. I'm going to give it to you at the end, go straight through so that we get it all done. Is that okay with all of you? Okay, good, making sure. Get your phones and go to kahoot.it. And you'll be pushing on your phone, but looking at the questions on the computer. You also will be getting this in the announcements with your recording tomorrow, okay? I also, for exams, I will give you every Kahoots that we've had. And I also will be giving you the recording so that you can go back and listen. I try to help keep you guys organized because I know 3 classes, it's rough, especially if you're working full time and have a family to deal with too. I like all the pictures they're giving me on Kahoots now. That's pretty cool. All right, let's get going so we get out of here. Week 1. It's going to go by quick, guys. From a worldwide perspective, infant mortality in the United States, the amount of infants that die in the first year of life compared to the world. Is higher than many of the other developed nations. I think Switzerland is the one that has the best rate, if I'm not mistaken. They got a better healthcare system than we do. The leading cause of death from unintentional injuries in children is injuries, children. You know, children do many, many different things. And it's motor vehicles. Remember I said this is where most of the unintentional injuries come from, whether they're in the car seats, in them improperly, or ran over by the car. This is why a lot of your cars have rear backup cameras now, because of children being and people being run over. Did you know that? Which statement is most descriptive of pediatric family-centered care? Remember, if you're working pediatrics, you're dealing with a whole family. It's the only constant in their life. I mean, family is always going to be there. And all they know is what the family has taught them up to a certain level until they get with other kids. You know, when they start going to school and be involved in birthday parties and all that, then they start to see some more. The major cause of death for children older than 1 year old is what? You know, you look at toddlers, 1 year old, they are the explorers, right? Aren't they climbing up on couches and jumping from couch to other couch, missing it, falling on the floor? I've seen them climb up dressers to get to the TV set, and the dresser and TV falling over on them because they didn't have that latch on the dresser, so it all fell on them. I've seen crazy things with toddlers. I call them my dive bomb kids, because they really are. The nurse caring for the child in pain understands that distraction So distraction works and it helps decrease pain, but it has to be on the level of the child. So developmentally appropriate to refocus their attention. You try to do something like give a sticker to an infant, what are they going to do with that, right? Maybe the infant needs like a rattle or some noise or some visual stuff. So making sure it's on their level. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? So without a mutual goal is called associative. They're doing the same thing, they're building something together, but there's no goal in the end. Cooperative is when there's a goal in the end, okay? Parallel, they're doing things next to each other, but not doing the same thing. They have their own little toys they're playing with. And of course, solitary, they're playing by themselves. Which statement best describes the process of critical thinking? Remember the first day of nursing school, they taught you that you have to learn what critical thinking is? And you're like, oh my God, when am I going to learn what that is? Well, many of you need to go make dinner, right? You look at the cabinets, what you have, what you don't have, you go to the grocery store, you buy it, you come home and you make it. That's critical thinking. Nursing works the same way, a little differently, but it's purposeful and it's goal directed. What is probably the single most important influence on growth at all stages of development, from infant to elderly? That is nutrition, nutrition, nutrition. Very good. Frequent developmental assessments are important for which reason? Like, why do we want to see if the kid is rolling over or be able to grasp your hand voluntarily or is walking? Why do we need to know these things or look for that? Because we need to identify these delays and deficits, because we can institute early intervention. We can, and what would we do? Well, if they're 1 year old and they haven't spoke or verbalized any words, well, maybe speech therapy, or maybe getting them for hearing tests. We need speech therapy, occupational therapy, physical therapy, or looking. We want to get that kid caught up. And what's the best thing about children? Once you institute a therapy that they need, these kids catch up really quickly, as long as they're getting what they need. So as soon as we can, give it to them, and it will work. Which function of play is a major component of play at all ages? It's that sensory motor activity. And let me tell you, it's why it's not the other. Because they touch and feel and they examine whatever in their mouth and play with it. And that causes creativity, socialization, and development. It's that initial feeling it, touching it, tasting it, and moving it that creates the other, okay? 3 children playing a board game would be an example of what type of play? So a board game has a goal. Somebody's going to win. And it's cooperative play. Associative, kids play together, but there's no goal in the end. They're just playing together. Cooperative means they're playing together with a goal. What are they going to do? And checkers is a great example of it. The head to tail direction of growth is deferred to as what? They lift their head, they roll over, they get on their knees, they crawl, they creep, they walk. It's head to tail. And it's called cephalocaudal. Cephalic is head, right? So that makes sense now. Cephalocaudal. What is the single most important factor to consider when communicating with children? I mean, I need to go in there and talk to a kid and have him take his medicine, or I need to do a blood pressure, a temperature. What I'm going to do first, literally. I want to get on their level. I mean, the older kids, they might be wearing a Batman shirt. And I'm going to go, wow, I love Batman. You know, I just bought my grandson Batman shirts and we have matching ones, or, you know, something to make them feel like I'm talking to them, and then maybe talk about school or, you know, extracurricular activity, something. Get on their level, and that kid's going to trust you then. Just don't go in there and touch. It won't happen. What 2-year-old pain assessment tool should the nurse use? We've talked about faces, numeric, and FLAC. 2-year-old is FLAC. It starts to be faces at preschool, which is 3 years old, okay? Make sure you know that. That's one of those questions that you're going to see, because faces starts at 3. A 6 months infant's birth weight should be what? At 6 months old, an infant's birth weight should be what? Again, we're going to go over these next week. I'm introducing these things to you. It's part of the assessment chapter, so I have it here. So at 6 months old, it doubles. At 1 year old, it triples. And we know if it's not where it should be, too much, too little, an intervention needs to take place because proper nutrition is important. And too much is just as bad as too little. The first expected fine motor development milestone for an infant begins with, remember, fine is fingers, right? So what do you think the first one would be? And it's going to be a reflex palmar grasp. Have you ever heard a newborn baby and the parent goes, oh, look, you just hugged my finger? It's this, you put your finger next to their hand and by reflex, it's their palmar grasp they get. And then you put something in their hand, it becomes voluntary. And then it goes into this pincher grasp, but it's crude at first, like a smush of Cheerios in the mouth in the high chair. Then it goes into a little neat little pincer grasp. Then it goes into putting objects into a container about 11 months old. And then at 12 months should be a block, 2 blocks like that. That is part of expected fine motor development. Remember, fine is fingers. An 8-month-old infant should be expected to perform which fine motor skills? Now, according to just what I just said, where do you think that would be? They should be able to voluntarily grasp a rattle, and they should be able to do that crude, pincer grasp. Very good. And then after that, it's into the container at 11 months, and then a block of 2 by year. The natural physical developmental sequence that most children follow is, what's the first thing that they do? They lift their head, roll front to back, back to front. They creep, they crawl, they cruise, and they walk. And that should happen in the first year, according to the book, but it may take longer than that or shorter than that, depending on the child. As long as they're moving forward, it's good. Which behavior indicates that an infant has developed object permanence? So object permanence means even though I can't see it, I know it's here somewhere. Let me go looking. It's like the older kid, get to be 1. You take their toys at the end of the day and you put them in their toy box. And all of a sudden the kid goes over and pulls it out. Still knows it's there, but it's not in eyesight. In general, an infant should triple their birth weight at what months of age? And that's at 12 months. So double at 6 months, triple at 12 months. These are very important things to monitor because they could have failure to thrive. They're not big enough. They don't weigh enough. And remember, cognitively and physically, they're not going to be where they should be. So nutrition is so important. Too much is also bad too. If you have a 6-month-old who's tripled their birth weight already, are they going to be able to get up and creep and walk and do those things? No, they're too big. So both ways are something that needs an intervention. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning that exam is what? Preparing for it on the child's developmental age. That's number one. I mean, the parents there are not as important as getting on their level, because you're going to be touching that child and you need to make sure that child's going to be attentive to you. Takes a little time, but in that little time that you have taken, you've saved a lot of time in the long run. According to Piaget, toddlers are in the blank developmental stage. You don't know these yet, but you're going to get more comfortable with them after next week. And it's the sensory motor. Again, they are cognitive, are starting to learn and being aware. So they're starting to explore their environments. They're touching and feeling and textures. And then, of course, exploring the world through their mouths and then moving things around and seeing how they work. It's all developing their cognitive mind, how things work. Which intervention helps a hospitalized toddler feel a sense of control? I've always thought taking a toddler on vacation was an extremely difficult thing to do. They don't want to sleep, they're cranky. And the reason is because they're not on their same schedule, right? So in the hospital, we can work around a toddler or even a preschooler's, routine. We can follow their routines, the foods they eat, if we can, their sleep schedules. We can work around that. And that child's going to feel a lot more comfortable and be less worried in that environment. Because hospitals, we change everything on them. All children reach developmental milestones at the same age, yes or no? Absolutely not. You'll hear parents come in and say, well, my child at 8 months old was doing this, but this new kid is not. They're not doing that, and I'm worried. And again, the thing is to tell them that all children reach developmental milestones differently, and that as long as they're progressing forward, they're doing okay. And we'll evaluate again on next visit. Immunizations for a 4-month-old infant. Which action should a nurse take to provide atraumatic care for an infant? Atraumatic care for an infant. So give them a pacifier. You don't know how many times we'll take and give immunizations, or we'll have to start an IV or draw labs or do a urinary straight calf on these children. Give them a pacifier, have mommy hold their hands, and she can be talking to them. And these kids, it's done, it's over, and they barely even felt the needle go in for IVs. So it works well. Again, my grandson had his circumcision with, just the pacifier. It works. Crying, yeah, they're going to cry a little, but it's going to be a lot shorter than without using that. Which of the following immunizations can be administered to a newborn? Now, if you open the book, chapter 31 is infants, and you're going to see this 2-page thing on all these immunizations. One of the things you need to know is what their first one is, and to understand that we give a lot of immunizations quickly, 2, 4, 6 months, and 15, 18 months, and 2 years, and 3 years, because children are born and mom's immune system is going to wear off pretty quickly. So they need to build their own. Now, the one that we do give as a newborn, usually before they leave the hospital, is hepatitis B. Okay, that's the important one to remember. And as we go forward, I'm going to teach you the more next week, but you don't need to know everyone and all the time frames on them. Okay, it's a lot of information. Normal heart rate for an infant. So it's 140 to 160, and that's at rest. If they're crying, it could be 200, okay? So 140 to 160 would be your baseline for that. Beats of 80 on an infant, it's too slow. That's very much too slow. 120 it could be, but 80 is way too low. 60, no. 40, no. You better start doing CPR at 40. What is the preferred site to give an infant an injection? And that's the vastus lateralis. Again, that picture on that one, that nurse doing it alone, absolutely not. Again, have that parent holding that child and have another nurse hold the legs so they don't move and you don't scratch or injure the child with that needle because they are sharp. The death of an infant under 1 year old with no known cause is known as what? And that's one of the reasons why they have made the program on back to sleep. Old infants should be put to sleep on their back. You know, at one time they even said they could be on their side, but they felt they were inhaling their own CO2 back and that could cause problems or they could roll over into it. But now it's completely on their back and it has decreased the amounts of SIDS death quite a bit. I know the hospital that I used to work at has been doing an ongoing investigation of their newborn ICU graduates at home to see the incidence of SIDS death has gone down drastically. So that is an awesome thing. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why doesn't she look at the nurse? Again, this is understanding cultural, right? And again, if you don't understand something, if you ask a parent, they will never be offended. In fact, they will be appreciative that you asked, okay? And it is respect, absolute respect for the nurse. It's their culture, the way they are. A child from Mexico is hospitalized for a serious injury, and the father says the child is being punished by God. Why does he think that? And it's just a common health belief. I mean, I've mentioned quite a different, couple different cultural things that go on. Just be aware of it. So if you're seeing something different, I'll tell you, just ask that parent. They will be very happy to answer you most of the time. So don't be afraid. They'll respect you even more that you did ask. Which term refers to times in an individual life when he or she is more susceptible to positive or negative influences? Again, this is part of the word group that I want you to look at the beginning of the chapters just to see what these phrases mean. I think once you see the answer, susceptible to positive or negative influence is when they're most sensitive, right? Sensitive periods, it makes sense. What is characteristic of the pre-operational stage of cognitive development? Again, this is going into what's going to go on next week. I'm just telling you there's different stages. And remember, cognitive is all about the way children think. It's understanding how old are these kids at this stage and how would they understand, right? And these children at this age need to see it to understand it. They can't say, well, if this happens and that, this much happened, which is logical. They don't do that. They have to see it work. You can take the rattle, shake it, and they hear the noise. That's concrete. They heard the noise, okay? Or I took my glass, I threw it on the floor, my sippy cup, and mom came. Oh, if I throw my glass on the floor again, mommy's gonna come back over to me, okay? These are concrete. They have seen it. They visualized it. Last question. According to Kohlberg, children develop moral reasoning. What is a preschooler stage of moral development? What did I tell you about Kohlberg? Do you remember? If not, again, we're going to go over it next week. Remember, Kohlberg is good and bad and a consequence for either. So actions are determined as good or bad in terms of their consequence. You know, as children get older, they do sometimes bad things because they wanted to do it and they knew the consequence, but the consequence was not as bad as not saying something. So they're going to do it anyway. So it gets, as they get older, it gets more involved. Let's see how we did today. You did your first Kahoots. Olivia, good job. Number 2, Brittany, whoop, 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 whoop. Number 1, Deanna, whoop, whoop, good job, guys. And then Miss Nookie and Carrie. So you've had your first experience with Kahoots. You can see how I take today's information and I put it here and try to show you a little bit more about it. I also try to explain it again to you so that you can understand it. Did you enjoy today's class? You guys have a great
Yes.
evening. Anything you need, holler, 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 okay? I will answer it. There's no silly questions, all right? Just let me know. And I'll see you again next week. Remember, next week is your first quiz at the end of the class. So see you guys.
Thank you. See you.
Bye. Thank you. Bye.